So yeah, as you might have got a message there, this webinar will be recorded today. This is the first of 4 Monday lunchtime webinars that the MR-SIG are running on the magnetic resonance in radiotherapy. So yeah, thanks for coming along today. So if you could please have your microphones on mute. You feel free to leave your camera on or off as you please. If there's any questions, please put your questions in the chat. And what we'll do is I'll invite you to come on and ask your question, turn your mic on and your camera on, and we'll try and get a little bit of a discussion going on afterwards, but we'll keep the questions till the end. So I should have said at the beginning, yeah, I'm John McLean. I'm the chair of the MR-SIG. I'm based at the Queen Elizabeth University Hospital in Glasgow. And we're going to have a talk today on governance in MRI for radiotherapy planning, MRI safety and staff training. And today we've got 2 speakers. We've got Lisa McDade. So Lisa's the principal radiographer working in MR research in the radiotherapy department at the Christie. Lisa's a diagnostic radiographer and has worked in radiology MRI services for over 20 years. She's heavily involved with procuring the MR scanner for the proton service pre-treatment area and has now moved over exclusively to radiotherapy MR services in the last 4 years. Dr. Sarah Wood-Spires is a MR safety expert and clinical scientist in MRI in NHS Greater Glasgow and Clyde and works mainly in the diagnostic MRI. But she also provides MRI safety support to the Beatson Cancer Centre's MRI scanning for radiotherapy planning, which was installed in 2021. So yeah, we're glad to have both Sarah and Lisa here today, and I'll pass over to Sarah to get started.
Thanks, John. So this is governance in radiotherapy planning, MRI safety and staff training. In the first part of the talk, I'll start with the safety concerns in MRI and the additional considerations for radiotherapy planning. Based on the guidelines for MRI safety in the UK, I'll talk about the place, the people, the equipment, and the management to be considered in MRI for radiotherapy planning with some examples. And in the second part of the talk, Lisa will present an approach to staff training and education. So here's an MRI scan room with our patient set up in the scanner. If you come from diagnostic imaging, this looks like a generous space in the center. It's a 70 centimeter bore. If you come from radiotherapy planning CT, it looks less generous. This is narrower than your radiotherapy planning CT, and the bore is a lot longer. Other than that, the room might look quite familiar from CT, but of course it's very different, both different considerations for both the imaging and the safety. Under the covers, a typical MRI scanner has a superconducting magnet, shown in blue here, which is cooled by liquid helium, and this creates a strong magnetic field in the center of the scanner. We then have our gradient coils indicated in green. We can run currents through these to change that main magnetic field slightly, and we need these to turn any signal from the patient into an image. The third component is our radio frequency or RF coil, shown in orange here, and this is needed to transmit a radio frequency pulse of energy to the patient to create a signal. We then need other RF coils that we place close to the patient to receive the signal. A scanner for radiotherapy planning may also have a separate gantry for the laser for lining up your patient to their tattoos or markers. You may have a flat indexed insert for the table, coil bridges to position the coils close to the patient without resting them on the patient so that you're not changing the patient contours. You'll also have positioning aids and possibly immobilization to get the patient set up in the treatment position. And this may include putting their arms above their head. So suddenly the 70 centimeters doesn't look quite so generous. The first thing we learn in MRI safety is that our superconducting magnet is always on. It's ramped up at commissioning, and provided there's enough helium to keep it cool, it will remain on until it's decommissioned 10 years or so later. So even if the power is off to the hospital, your main magnetic field is still on. This means the magnetic field in your scan room may be high enough to have an adverse effect on medical devices and implants. And within the scan room, there's a risk that the attractive force and torque on ferromagnetic objects can turn them into dangerous projectiles. They can quickly be pulled out of your hands and out of your control. Projectile incidents can kill people instantly. And some famous cases include in 2001 in the US, a 6-year-old boy was killed when his head was hit with a steel oxygen cylinder. He was getting a scan prior to leaving hospital under general anesthetic. And when the piped oxygen supply to the room failed in the ensuing call for oxygen, a hospital staff member brought a portable oxygen tank into the room, which was attracted to the magnet and struck the child in the head. This sparked a huge overhaul in MRI safety worldwide, but there have been incidents since. There was an incident in the UK of an unsafe oxygen cylinder brought into the room, thankfully not resulting in injury. In 2018 in India, in 2021 in South Korea, there were deaths of a relative and a patient due to unsafe oxygen cylinders being brought into the room. Another incident that was in the papers is in 2019 in Sweden. A staff member was injured by wearing a weighted exercise vest into the room. This was ferromagnetic and they were pinned to the magnet. And for each of these incidents that results in serious injury or death and that makes the papers, there will be numerous reports of an MRI unsafe trolley, the wrong wheelchair, the wrong monitoring equipment brought into the room. And it's often just a case of luck that it didn't result in more serious injury. So this hazard is present all the time. Consider in radiotherapy, for example, the use of carbogen cylinders. That may be a similar risk to your oxygen cylinders. Is there a clear procedure for where these are placed and how they are used? For smaller objects, this main magnetic field is a concern as well. When we think about small implants, if there are any ferromagnetic implants, the movement and twisting of these implants could present a risk of injury to the patient. In the 1990s, there was a patient death due to a steel aneurysm clip twisting in the magnetic field. There was a report of a patient blinded due to metal fragments in their eye moving. So this hazard is present all the time, and we must keep this in mind whenever we're entering the MRI department or the MRI scan room. During a scan, we're applying these pulse sequences, which are a combination of lots of radio frequency pulses and switching on and off the imaging gradients. And these give us some additional hazards. The RF pulses can cause heating of tissue and a rise in core body temperature. And so the power deposited in the patient has to be limited. And this is limited by the SAR limits on the scanner. Even within the SAR limits, there are several ways that inappropriate positioning of patients could cause the patient to be burned. If any part of the patient's body is touching the sides of the bore, this can result in a burn. If there's skin-to-skin contact within a large current loop within the patient, so for example, the patient's hand touching their thigh or the patient's knees touching together, which could create a current loop around their legs, that point of high resistance where the knees are touching can result in a contact burn at that point. We also have the possibility of, for any metallic or conductive objects in or on the patient, depending on the size and shape of these could heat significantly due to induced currents and result in a burn. And this is a particular concern for implanted medical devices that have long leads. We also have the issue of interference for active implanted medical devices. From the imaging gradients, subjects may experience peripheral nerve stimulation, and this switching of imaging gradients is what causes the noise of the MRI scanner. So anyone in the room during a scan must be protected from that acoustic noise, including the patient. Everyone must wear ear protection. Our scanner is cooled by liquid helium. There are now some scanners with closed systems and very small amounts of helium, just a few litres, but the majority of scanners have about 1,500 litres of liquid helium. In these, if there's a leak or a quench, a large amount of helium gas would be released. And if this is released into the scan room, this displaces the oxygen and presents a risk of asphyxiation. So we need a quench pipe to ensure that any helium gas vents to the outside, an oxygen sensor in the room, which will alarm if the oxygen levels drop, and an emergency extractor fan to clear helium gas from the room. So all of this is important for any MRI scanner. In radiotherapy, we have some additional considerations. We potentially have a wider group of staff that may require access either to the MRI department or to the scan room itself. And these staff members may not be working in MRI all the time. They need appropriate training, but they also need that constant reminder of the environment that they're working in. The positioning and immobilization aids need to be checked for MRI safety, but also this immobilization has implications for the patient's comfort, for their ability to communicate, and for their safety. For example, if there's an incident with the patient and we need to evacuate them from the scanner. And with this wider staff group requiring access, staff may come from several different departments. If we have these different departments coming together, that presents a risk in itself. We have these highly trained staff groups, but they are coming from different departments. So if we're coming from the diagnostic imaging department, we may have made some assumptions that don't translate to radiotherapy imaging and vice versa. We need to know what each person's role is and have additional training to ensure that we all know how the process is working. So the core people involved in your radiotherapy planning MRI scan are listed here. They may be sitting within your radiotherapy planning department or within your diagnostic MRI department. If your MRI scanner is for radiotherapy planning only, it's an MR simulator all the time, then it may be managed by your radiotherapy department. And within that, you may have radiographers originally trained in diagnostics and radiographers originally trained in therapy. And you may have clinical scientists in radiotherapy who will know the purpose of imaging, the requirements for registration, and will be very involved in the use of the scanner and the setup of the sequences. You'll also need input from your MR safety expert who may come from your diagnostic imaging department. For your image purpose, this will be led by oncologists, but ideally you'll have input from radiologists for image optimization and sequences. For a scanner that's shared use with some sessions for radiotherapy planning, this may be managed in diagnostic imaging with diagnostic radiographers leading on scanning and therapy radiographers assisting for patient positioning. This will still need setup of sequences from radiotherapy imaging physicists, from your MRI physicists, and involvement from radiologists and oncologists. In either of these cases, we need additional training for the radiographers and the clinical scientists so that everybody understands the risks from MRI safety and the purpose of radiotherapy planning and the requirements for image registration. So with correct training, this distinction of originally diagnostic or originally therapy radiographer may be less important. And there are clinical scientists training in dual specialism with radiotherapy and MRI who will hopefully bridge this gap in the future. So in the future, this whole department should become more harmonized. But there is more of a risk when we have different staff groups from different departments coming together. Everyone needs to be clear on the responsibilities for each role and all need appropriate training. On the ground, work instructions and documentation become even more important, for clear communication. And we need governance to ensure that this is happening. So there are several key pieces of legislation that are important in MRI safety in the UK. But they are tied together in the MHRA guidelines for magnetic resonance imaging in clinical use. The application of these guidelines to radiotherapy planning was considered in the IPEM topical report, the guidance on the use of MRI for external beam radiotherapy treatment planning. And both of these documents should be considered required reading if you are working in MRI for radiotherapy planning. Starting with the layout of the department and the need for a controlled access area now. Because your MRI scanner is always on and we always have this strong magnetic field, we need to define a controlled access area. On the picture here, we've got the layout of a simple MRI department. You can see the MR environment marked in orange, which is your scan room and any other areas that have a magnetic field greater than 0.5 millitesla. So usually just your scan room, but may extend further than that. Within that, you can see this oval shape, the MR projectile zone. This is a region with a magnetic field greater than 3 millitesla. And this is the region where any ferrous metal object could be pulled out of your hand and become a projectile. The MR controlled access area is then an area that contains your MR environment, your scan room, and that is defined as restricted access. So this will include your scan room, your technical room, your control room, and may include your patient prep area, your anesthetic prep area, but hopefully won't include your MRI reception, for example. So controlled access means that only MRI authorized staff can access the area unsupervised. Anyone else needing access must be supervised and must be safety screened prior to entering the area. And we must also have control of equipment coming into the area as well. So this may be key card operated, for example. Onto the key roles, the who's who from the MHRA guidelines. Every MRI department must have a named MR responsible person. This is someone who's responsible for the day-to-day safety of the MR controlled access area. They have to ensure that local rules and documentation are in place, that training is in place for staff. They're involved in assessing equipment, and they must approve MR authorized personnel. No one can become an MR authorized person without sign off from the MR responsible person. There are several people that may fulfill this role, but typically this might be your lead radiographer. You also need an MR safety expert. This may be someone within your department or maybe someone giving advice external to your department. This is someone the responsible person can consult for MR safety advice. They can advise on equipment, on techniques, on implant safety, on the safety framework, and so on. And this is typically a clinical scientist in MRI physics. Also mentioned in the MHRA guidelines, we have the clinician or supervising radiologist who's responsible for the safety and well-being of the patient within the controlled access area. In diagnostics, this would typically be a radiologist. If you have a radiotherapy planning only scanner, then it may be appropriate for this to be an oncologist. So this should be someone who has appropriate MRI safety knowledge to fulfill this role. And we also have mention of the referrer. They need to provide complete medical information for the patient to allow us to identify patients with implants or contraindications to MR. And this is the first stage in our safety screening, really. In diagnostics, incomplete referrals are quite a big problem. But you maybe have a clearer pathway for referrals and a smaller group of referrers in radiotherapy. It's usually just your oncologists and specialist radiographers. So there's an opportunity there to make sure that the referrers are appropriately trained in MRI safety and their responsibilities. And this is particularly important if they are also the accepting clinician and you don't have a radiologist involved in that process. So MR authorized persons are those people who can enter the controlled access area unsupervised. There are different classifications of MR authorized persons, depending on whether they are able to enter the MR environment and whether they are able to then supervise people within the MR environment. They will all have additional MRI safety training and they must have been signed off by the MR responsible person. There are lots of people that may require this authorization, in particular your therapy radiographers, diagnostic radiographers, clinical scientists in radiotherapy and in MR. But this may also extend to healthcare support workers, technologists, brachytherapy nurses, play therapists, and so on. Anyone who is not MR authorized must be supervised and screened when in the MR controlled access area. And it's important to keep the controlled access area restricted to only those who need access. But if someone is required to enter the MR environment frequently, we mustn't fall back on them always being supervised. They should get that additional training to become MR authorized person. On to patient positioning equipment now. There may be some equipment that's not suitable for entering the scan room, the MRI environment, because it's MR unsafe. Control of this equipment should start at the entrance to the controlled access area. If it gets past that, there's a chance it could be brought in the room. And in particular, you should consider what might be expected to come with the patient or what might be grabbed in an emergency. Some of the famous safety incidents come from failing to control what comes into the department or from forgetting that evacuation of the patient is the first step in tackling an emergency. But examples of equipment that might be used for positioning the patient include a wing board, vac bag, compression devices. These must be assessed by the MR responsible person with MR safety expert advice if required. They will consider the typical MRI safety. Is this ferromagnetic? Is it electrically conductive? But also the other safety implications. Does it hinder communication for the patient? Does it make evacuation of the patient from the scanner more difficult? Does it thermally insulate the patient and mean that they might heat up during the scan? Once this has been assessed, it can have an MR safety label, either be safe or conditional, and it must be documented, documentation on the conditions and where it's kept within the department. It's really important if something is to be used in MRI only, that it's kept within the MRI department, and beware of anything that maybe has a similar MR unsafe equivalent elsewhere in the radiotherapy department. Make sure that you have the right device in your department. Any MR conditional devices that might have an unsafe attachment or any devices that might have been modified. It's important prior to entering the scan room that all MR authorized persons pause and check that this is the device that is MR conditional or safe, and check that with a magnet if needed. All departments should have a strong handheld magnet to test items to be taken into the MR environment. Departments may also have a ferromagnetic detector, either a wand or a detector mounted on the walls. These are recommended in the ACR guidelines, the American guidelines, but are not required by the MHRA. They do not in any way replace the need for screening. They can be a useful adjunct as a kind of final check to catch anything that's still with the patient. So they may be useful, but it's important to make sure that you understand the limitations of ferromagnetic detectors. They don't catch everything, and you must be aware of those MR conditional devices that maybe have small ferromagnetic components. And you must have a process for how you're checking things if you are using a ferromagnetic detector. Onto the MRI safety management structure now. You hopefully will have a well-established MRI safety management structure within your diagnostic radiology departments. So does MR for radiotherapy planning fit into this, or does it create something equivalent? Well, for the most part, when it's appropriate, it should fit into the existing MR governance structure. For example, in the MRI Safety Committee, if you have one for your health board or health trust, then your radiotherapy planning MRI scanner can also report to that committee. So we have an example here where our MRI Safety Committee reports up to our Radiation Safety Committee. The MRI Safety Committee is chaired by the General Manager of Diagnostic Imaging, and representatives from each MRI department sit on that committee. This is always including the MR responsible person and the MR safety expert. It may also include radiologists from the department. For the radiotherapy MRI scanner, radiotherapy imaging physicists, the MR responsible person and the MR safety expert now sit on the MRI safety committee. For local rules, every department needs MRI local rules. We were able to start from diagnostics local rules templates, adding additional department-specific details. Our work instructions are generally local, and these are particularly important for shared staff groups or for any additional equipment that's used. Our safety screening forms are similar to those used in diagnostics. And these are all stored in our radiotherapy quality management system. But we also have access to this system for key diagnostic staff, such as the MR safety expert. Similarly, radiotherapy staff have access to the diagnostics quality management system so that they're able to see the equivalent documents in the diagnostics system. So it's important that we have access to both of these systems and that key staff on the ground are making sure that these documents don't accidentally diverge. There may be a good reason that they deliberately diverge if there are different requirements in the departments, but having documents updated in one department and that doesn't roll out to another department would not be great governance. So both through the MR Safety Committee and by having access to each of these systems, we ensure that we keep these on track. Radiographers in therapy also have access to the Diagnostic Radiology Information System and PACS to be able to see the patient's previous MRI safety checklist and imaging where appropriate. For risk assessments, some risk assessments are shared across the health board and some may be local to the department. Our implant safety policies are shared across our health boards, and we have adopted these, but we have some special consideration for the impact of an implant on artifacts, which might be more of a problem in radiotherapy than in diagnostics. Onto our local incident reporting and investigation. Any adverse incidents must be reported early with as much information as possible. Within our online data reporting system, we have to specify the location of the incident, and if this is the MRI department, then the MR responsible person and the radiotherapy imaging physicists are automatically notified of the incident. We also have a category for the incident for MRI safety, and if this category is selected, then the MRI safety experts are also notified of the incident. And within the MRI safety category, we have different subcategories for breach of local rules, RF heating or burn, equipment failure, and so on. These subcategories were agreed across Scotland. And it means that our MR safety experts are involved in investigating any incident that's relevant to MRI safety, but not necessarily involved in investigating slips, trips, and falls within the department. They can also then inspect incidents by category across the health board. Onto our annual safety audit now. For the acceptance testing of our radiotherapy planning scanner, the diagnostic MRI physicists, the MR safety experts, carried out a standard diagnostic acceptance test. There were then additional QA and acceptance tests carried out by the radiotherapy imaging physicists appropriate to radiotherapy. We have an annual safety audit that's carried out by an MR safety expert, and this is in place to test that the MHRA guidelines are followed, that safety-related documentation is up to date, and that the MR responsible person is supported in having enough time to carry out these tasks. So our safety audit is split into the categories shown on the right here. We have health board governance, training records, implant safety, MR quality assurance, and so on. In radiotherapy planning, MRI, unsurprisingly, the answers to the questions about MR quality assurance were incredibly detailed and much more in depth than in diagnostic MRI. And this is something that we would love to be able to take back into our diagnostic MRI department. There is some learning that goes both ways in this. We'll move on now into safety training in MRI. I'm going to pass on to Lisa to present the approach that she's taken in her department to safety training.
Thanks, Sarah. So we know from an IPEM report 4 years ago now that one of the biggest problems is that magnets aren't commonly housed in radiotherapy departments. At the time of this report, there were only 2 in the UK. That may have increased by now, but it certainly won't be into double figures yet. And one of the biggest risks, as we heard from Sarah, is safety. Apologies. I've got a time lag. One of the biggest risks is safety, because the magnet's always on. In conjunction to that, some of the issues in radiotherapy, our patient throughput is generally lower in radiotherapy compared to radiology. And so we've got less capacity for that experiential learning that you get when you have a busy service. And so any training and competencies that we develop and your learning guides, they need to reflect this and cover for it. So just to quickly recap, Sarah mentioned that the MHRA recognises the variable roles of MR personnel. And effectively, from a safety point of view, people leave their jobs at the door and they assume these roles in terms of MR safety. And what's really important is that any documentation you develop ensures that those learners, they recognise their scope within an MR safety perspective, where they can supervise, and more importantly, where they can't supervise other people. That must be captured within. Luckily, they do all have universal elements though, but we don't know what we don't know. And so thankfully for us, the MHRA do include in table 4 minimum knowledge requirements. So whenever you're developing any training documentation, any competencies, refer back to table 4, because that gives you your minimum knowledge requirements at each classification. So how did we do it? Well, those universal elements all came together to form our hub. We decided on a hub and spoke model for our competency framework, and the hub was really everything that was universal, and that includes completion of a basic safety training, completion of a safety screening form, and a requirement to read the MR local rules and SEMFAO regulations, control of electromagnetic field at work regulations. And they're really important for protecting workers in an MR environment. These are all completed annually. In addition, we do regular evacuation training for both clinical and non-clinical staff as well. Quite frequently in an MR environment, you'll have a minimum number of staff, as Sarah mentioned. In the event of an emergency, you have to get your patient out quickly. And so everyone needs to know their role. And the only way you do that is by regularly practicing evacuation training. In addition, for staff on the MR LINAC, radiation local rules are obviously obligatory as well. And what that means is that this allows our staff, this is how we classify them, as MR authorised persons for the MR environment. But if we're going to be responsible for other people, we're going to work as MR authorised person supervisors. We need additional training. We need enhanced safety training, and we need safety screening training, which is vital. And by doing these competencies, this allows us to work as MR authorised person supervisors. Okay. And for staff who are going to image patients, we need more. And so we developed an MR imaging only competency for staff who are going to work as clinical operators. So what do these competencies involve? So we'll look at the safety competency first, and it comprises a set of learning objectives. As I say, these learning objectives align with the basic minimum requirements from the MHRA with regards to an MR authorised person supervisor. So these are all the things that the MHRA say they must know as a bare minimum. So these are the competencies. So on-the-job training is really important. These are practical skills. So we develop the learner guides that learners complete on the job. As we mentioned, that the experiential learning is perhaps a bit less in radiotherapy. So we wanted activities interspersed in the learning guide that get the learners thinking about practical things from a safety point of view that are going to help them. So things like, where's the maximum spatial gradient? Where's the maximum accessible spatial gradient? These are really important when it comes to imaging patients with implants, active implants. It's also really important from a basic safety point of view of where to stand. The maximum spatial gradient is usually round about head height if someone stood next to the bore. So if you know about things like that, if someone comes in the room and looks like they may have a ferromagnetic object in their hand, you move out the way. The safety screening competency. Safety screening is vital and is one of the most important parts of a patient pathway for MR. If you don't screen a patient adequately, you do run the risk of causing life-changing or even fatal injury. And it is not to be underestimated. It is not a tick box exercise. It's absolutely essential that how you train your staff to do safety screening, to undertake safety screening, they don't view it as just a tick box exercise. They learn how to screen. They develop critical thinking skills when they're screening. We want these screening forms to be fairly concise, otherwise people get bored filling them in, but they need to promote questions. We need to look at body language when someone's answering these questions to delve further to find if people do have anything implanted within them that could cause accident or injury. So these are the learning objectives. And then an example of the activities are looking at conditionality. You know, what other things do you need to think about in terms of conditionality as opposed to the static field? Imagine we're screening patients and they come along with unsafe devices attached to them. How do we deal with it when we can't just simply take it off? We have to learn to deal with it. And hearing devices as well, they're really commonly worn. They fit into many MR safe, unsafe, or conditional classifications. Some are removed, some aren't. We need to know, and we need to also know how to deal with a patient who, if we're taking one of their sensors away and we're putting them into a magnet, we need to know how we're going to communicate with them as well. So all of these things, these critical thinking skills, we need to be teaching within the competencies. Screening is a practical skill, and so when learners have finished summative assessment, they'll then screen 10, 12 patients under supervision to make sure that they feel happy screening. It's something you do learn through experience. You learn to read body language. So 10 minimum, and then they complete the competency. And what we also like to tell learners is you will find scenarios that you don't know what operation that a patient will tell you they have a device or they've had an operation. You don't know what that means. Just tell them you'll find out. We don't expect you to know everything. But what we do expect is that if it's something you don't know, you will go away, you will learn what it is, and then you will go back to the patient. Manufacturers are changing devices all the time, and development with new technology is coming all the time. So we need to be on top of that, and we keep on top of that with the critical learning skills. So imaging only, it's a summative assessment. Again, it's a practical. We want them to explain the parameters that they see. MR is not like CT. So we have our basic learning objectives, and then we have practical activities for them as well. Falls into safety because of distortion testing. We need to know if we have images that have distortion within them, then it becomes unsafe from an image registration and a contouring point of view. So it's bringing that knowledge in. And then we have a practical assessment as well, because imaging only is a practical. So how do we get our patients ready? How do we scan them? And that's part of the practical assessment with some activities as well. For the common problems that we tend to hit when we're scanning, things like the surveys in the wrong place. We set our surveys up to run in a certain particularly coronal plane. Then we put our patients on a vac bag, and all of a sudden they're 6 inches up in the air. So we need to know how to do those practical things. And then we have based our practical assessment on the Society and College of Radiographers document, pause and check. And on the next slide, there is the actual assessment. So learners will go through that. So to conclude, MR, it can be a really dangerous environment. We have to manage it carefully. We're still getting fatal and life-changing accidents happening. You know, it's 20 years, 21 years since that infamous accident in New York when everyone said never again, and we're still having fatal and life-changing accidents. So people, the root cause of these is very, very often it's either ineffective procedures, poor safety knowledge, or human error. We shouldn't be having them. To avoid them, we try and equip the workforce. We need the knowledge, the skills, and the competence to provide that safe environment, not just to patients, but to staff as well. We need to be able to safely screen our patients, staff, and any visitors to the department, because that helps safe scanning practices and avoids those incidents, those burns, those injuries that we see and hear about and read about. And also vital, we need competence and documentation. We need to evidence how we are complying with the mandatory requirements from the MHRA for the different roles within the teams. MR is a very different type of environment to lots of other clinical teams within the hospital. It's quite unique. And we need to ensure that everyone working within that team understands what their role is and what their requirements are and their expectations for MR safety. And that concludes. If anyone has any questions.
That's great. Thanks very much, Lisa. Thanks very much, Sarah. Find the button, hit some virtual applause for you now. Well done. There's already been a couple of questions in the chat, but I can invite Robert to come. I know there's been some responses, but I'd like to give Sarah and Lisa a chance to respond to the questions as well. Robert, are you there? Do you want to come on and just ask the question that you put in the chat? Would that be all right?
Hello.
Hello. Good to see you, Robert.
Sorry, it took me to find the buttons. The first question was just whether you got any experience with the ferromagnetic detectors, and whether for an RT specific scanner, whether you'd consider them if they're not used in diagnostics.
So do you want to start, Lisa?
I can do. We have them. We have them on the MR-Linac because they're mandated by Alexa. So all MR-Linacs globally that go in will have ferromagnetic detectors. I will confess we've disabled ours because the evidence is ours are by the door, by the magnet room door, which is kind of, you know, shutting the if someone's got to that point, then your procedures have failed if someone's got to that point. But all of the research evidence is that they might help. They might see things, but nothing will negate screening. And there is evidence which suggests that people get fatigue, they get alarm fatigue. So it's going off and people think, oh, it's gone off because I've got my belt on. Oh, it's gone off because I've got my bra on. And there's no evidence that it reduces incidents, as far as I'm aware.
Yeah, we have them at the Beats, and I think Stephanie has already responded to you and could discuss further. At the moment, I think we have a good process for using it, but it's being aware of the limitations of that. If you think it's going to catch your MR unsafe oxygen cylinder attached to a bed, for example, that MR conditional bed may also have ferromagnetic components. So this is great for catching maybe the final thing that's on an ambulatory patient, but we have to have a process for how we're using it. In our case, I think we have the door closed, the patient approaches the detector for a kind of very final check of screening. This is after all other screening. And then on them entering the room, the radiographers enter first because they are not necessarily fully demagnetized. You know, I don't take my glasses off because that's another safety concern. So I would set the alarm off. So it's having that clear process. I would say that my kind of what I see of radiotherapy planning imaging is something that lends itself more to having this very careful process for each patient. Whilst we also have this in diagnostics, taking an additional 3 minutes over something is a huge impact in diagnostics. But in radiotherapy planning, those careful checks, that there is space for them. So I think, yes, we don't have them in our diagnostic imaging departments. We do have it in the radiotherapy planning department. And at the moment, I could see that it may be useful, but I certainly wouldn't have pushed to have it. It was others that were keen on it. So I think it will be useful. I certainly wouldn't get rid of it yet, but I wouldn't necessarily tell everyone they desperately needed one yet.
Cool, thank you.
I mean, I appreciate we've got over 100 people here today as well. Does anybody else from the audience want to comment on their experiences with ferromagnetic detectors, or before Robert moves on to his second question? Just come on and okay, I guess I'll move on, Robert, to your second question.
Second one wasn't so much of a question. It's, I'm really interested in your dual specialism training for scientists, trying to cover both radiotherapy and MRI. I was wondering if you'd be up for a chat about that sometime.
So I think Steve Gandy has responded a little bit on that, and I know we have a dual specialism trainee in Glasgow, and I know that there's one in Dundee as well. And I think this is, it really lends itself well to the dual competency. It's a place where we really do need that knowledge across disciplines, and whilst it's probably hard work for the first trainees going through it, as it always is in any new set, there is a clear way that you can meet competencies in both specialisms. I don't think it's a strange combination. And I think with the increase in radiotherapy imaging, MRI, there's a clear gap there that can be fulfilled in the future, near future.
I like that idea of it. It's good.
All right, that was me.
Any further questions in the chat? Cormac, you were making a point. Do you want to come on and yeah, well, Cormac was just making the point in the chat about the IEC, although that's changed the chem fuzz still to move, but like you say, hopefully that'll move soon.
Yeah, I couldn't find the buttons there either. It takes a while.
It's hard on a laptop.
My shortcuts were hiding things. Yeah, so this is really welcome, the 0.9 millitesla, which will help us design MRI departments, but I think in the UK it's going to take a while before we can really adopt them. But I suppose it could feed into our risk assessments if we have a bit of additional information there from IEC 60601-2-33.
Yeah, certainly. I think I'd be a little less concerned about the kind of exclusion zones we've got sitting in our waiting area, for example, though, where a 0.5 millitesla just extends into it. That's quite nice.
Thank you.
That's great. If there's not any more questions, I don't think that was. Or does anyone want to come on and? I guess, well, one question there is a little bit of time before past. I mean, I guess there'll be different people on here. Maybe people have got MR systems and radiotherapy departments, or already, or who are thinking about it. I mean, is there anything in hindsight? You've both been through this, Sarah and Lisa. Like in hindsight, is there something you would have liked to have done that would have helped the process for someone who's thinking about this? They could try and implement that.
I think from my point of view, it was quite an eye-opener starting being involved in the setup of a new department that wasn't sitting within diagnostic imaging, and making sure that all the key people are involved right from the start is really important. The sort of people that you might assume, that might automatically be involved in diagnostic imaging aren't necessarily automatically involved in the setup of a radiotherapy planning MRI. So that needs to be considered more carefully.
I think I'd second that, especially involvement of an MR physicist right at the beginning. If you're in a radiotherapy department looking to put a magnet in, sometimes an MR physicist isn't the first person they go to, and rarely they're the crucial one. You know, it's getting the right team there.
We sometimes have that problem in diagnostic imaging as well, Lisa. That's a separate problem.
Okay, no, great. That's great. Is there that final slide there? Do you want to bring up that one? Well, there's Cormac's going. Do you offer a GA service actually?
We do on our sim, yeah. We do.
Don't yet. We don't yet at the Beatson, but that may be in the future.
That's something to, if you are going to offer a GA, if you're going to, you need to think about that where you can at the beginning, in terms of your patient pathway, and whether the patients go to CT first, MR first, whether you're going to use the MR safe or MR conditional monitoring in CT as well. So you only have MR conditional kit. But you do need to, there's a lot of considerations for GA. And if you want to get in touch, I don't mind going through.
I would add as well, ideally considering it, even if it's in the future, considering right from site planning, get an anaesthetist involved, make sure the MR anaesthetic guidelines have been followed, but there is an MR trained anaesthetist involved from the start. I think there's maybe some assumptions that people carry from radiotherapy planning, where they're used to a very complex situation of anesthetics in radiotherapy treatment, but they're not used to, you can't switch off the scanner. You know, that they're dealing with much more in many ways than we have done in MRI, but there can be that gap. And I think as well, just making sure you have enough space in your patient prep area, all the things that you have to consider in diagnostic MRI as well. But if this is not something that can easily be added later, so even if there isn't the money for the whole thing yet, having someone involved in site planning right from the start is the ideal situation, if it is to be considered in the future.
Yeah, this
absolutely.
Is something...
And what I would second is if you're going to even consider GA, get your gases put in at the very beginning. We didn't for the MR Linac because we couldn't. Electa didn't install, and we had to retrospectively fit anaesthetic gases, and it costs a fortune because you have to ramp. We managed to do it without a ramp down, but it still costs a lot of money, and it was very disjointed. It wasn't the easiest thing to sort.
Yeah, this is something I'm helping design an MR sim system at the minute, and we're putting in the pipework for the gases and interfacing with the Faraday cage, even though we probably won't start this service for a while down the road. But it's so much easier to do it at the early stages, just a couple of pipes and get it sorted.
It is, but make sure you're getting the correct set, that what your anaesthetist will want for GA.
Yeah.
So that you don't then have to suddenly retrofit suction or medical air or something that they'll want for GA. Yeah.
Mm-hmm. Thank you.
That's great. There was one final question in the chat just about the recordings being available. So I believe that the recordings, they are going to be available. I don't know actually when. Maybe if James is there from IPEM, he may be able to comment exactly when they'll be available, but I would maybe guess after all the 4 webinars have run.
So we're looking to upload the recordings to the IPEM conferences YouTube channel after each one.
All right, great. So it should be available pretty soon then. Thanks, James. Okay, I think we've covered everything. Just a final wrap up. So yeah, thanks obviously to the MRSIG, and I think Jonathan Ashmore is largely responsible for organising this. So thanks to them, and thanks to James at IPEM office, and thanks especially to Sarah and Lisa for the 2 talks today. It was good. It was great. It's good to get a little bit of chat with people as well and see some faces. Thank you all.
Thanks very much.
Thank you.